Rock and roll.
If you take health insurance as payment, then choosing good payers makes sense, obviously. How do you figure out which payers to contract with? It's a very logical question that has a very involved, sometimes not so logical answer or answers. My guest today helps his clients work successfully with insurance companies, including which ones to contract with in the first place. And he's going to help take this very, very large topic and see if we can break it down a bit. I'm Carl White, principal at Market Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practice owners stay private. Usually that's what they want, but care is better when it's the providers of care who own the place, because then all the decisions, clinical, business, whatever, are made by those who are providing care. So we can rest assured beyond any doubt that patient care and what patients need are always top of mind. My guest today is David Zetter. David is the founder and president of Zetter HealthCare in Mechanicsburg, Pennsylvania, and has over 24 years of operational and healthcare experience. He's nationally recognized for his speaking presentations and healthcare business expertise. He is well versed in regulatory requirements, revenue cycle management, credentialing and contracting, compliance, and coding and documentation. He's considered an expert on Medicare, not only by his clients, but also through consultant colleagues and healthcare attorneys across the country. He's an expert on ERISA regulations, which protect over 80% of the claims in the US. He knows how to stop payer recoupments dead in their tracks and what is legal and illegal in many payer contracts. Totally relevant for our topic today. David, thanks for coming back to Practice Care.
Thanks for having me, Carl. Good to be here.
Yes, good to have you back. And we're going to tackle a beefy topic today, evaluating insurance companies and plans. Before we do that, though, fill in your bio for us, for those who don't know you or of you, didn't hear your prior episode from a few weeks ago. Tell us a bit more about you and Zetter.
Sure. Well, we've been in business for 25 years. We do a lot of work for a lot of clients all over the country. We have no issue working with any client or all clients in all 56 U.S. territories. So the 50 states, and then places like Virgin Islands, Guam, Marshall Islands, all those nice tropical places we all wish we were at.
Yeah.
So we help them everywhere. We work with independent practices. We will work with hospital-owned or health system-owned practices, but that's a rare occurrence. Simply because we tend to want to work with private practices instead.
Yeah.
So that's our bailiwick. Those are the people we love to help, and we try to do that every day.
Yeah.
So we do everything from startup practices, governance documentation, registration with states, productivity income split formulas, credentialing, contracting, compliance. There isn't too much we don't do. We do a lot of revenue cycle assessments, work with attorneys to evaluate billing services or companies, and then we can provide expert testimony as well if we have to, if they're going after that company that didn't do their job properly. So we get involved in quite a bit of stuff. There isn't too much that we aren't aware of, and we just love helping physicians and making them smile, because it's hard to get a physician to smile now.
And to hold the smile. Yes. Don't forget startups. You work with a lot of startups.
Yeah,
as well. Yeah. Which is good to hear. There are a lot of them. So evaluating insurance companies and plans. I mean, my impression from, obviously we use health insurance as a family, and working with, just listening to you, it's like the mother of all minefields and mazes is the world of health insurance. And so we're talking about, who do you contract with? It's like choosing which maze and minefield do I want to go into, which probably has some advantages. So let's jump right in. Big question first. How do you decide which insurance companies and plans? Because it's not just, each company's got numerous plans, just
Sure.
to add to the complexity to even contract with in the first place. How the hell do you do this?
Well, the first thing we do is, many times we always ask the client. Now we get clients that are brand new, starting out, they have no idea what to do. And then we have clients that, have been in business. Maybe actually most of the clients that we get are either one of two situations. brand new, need contracting and credentialing, or they've been in business and somebody really did a job on it.
Okay.
And they need it fixed.
Mm-hmm.
Meaning that they either weren't credentialed, they don't have contracts, all of that kind of stuff. First off is deciding which payers to contract with.
Mm-hmm.
A lot of times we're going to ask the client first if they've got an idea on which payers they need to contract with. If they're, let's say they're leaving employment and they're setting up their own practice.
Okay.
Well, they already have an idea on who their patients are, especially if some of those patients are going to follow them. And even if they're under a non-compete or restrictive covenant, you're still going to have patients follow you because it's their decision. The employer doesn't get to decide whether the patient stays with them or goes with you.
Yeah.
You may not be able to solicit them, but the patient can go wherever they want.
Right.
So when that happens, one, we want to know who those patients are so that we can make sure that we're obtaining contracts so they can see those patients as soon as possible. But normally we also recommend to them, look, we can provide you an evaluation of all the payers in your area or state. We can also help you evaluate it based on the number of lives covered under their plan.
Mm-hmm.
So we utilize a website that documents all insurers that are licensed in each state. We provide that information in a list, a spreadsheet for the client to review. We will inform them of who the payer is, the insurer, what the plan is, whether it's an HMO, a PPO, Medicare, Medicaid, exchange plan, and so on, okay? Mm-hmm. Because payers don't name their plans anymore in a contract. You will never or rarely find like Highmark Blue Shield's traditional indemnity plan. You don't see that in a contract. What you're going to see is they're part of their commercial network. It may say PPO, EPO, HMO, things like that, but that's about all you're going to get today from any payer.
That's so frustrating because on the consumer side, to me, there's too many names, but they all have, each name is too long and there's too many of them, but now you can't even cross-reference them if you're on the provider side.
Well, oh yes, you can.
Oh, you can, okay. Well, not by the name. Okay, keep going.
Here is how you're supposed to do it. And we inform all our clients they need to do this because there is no other way to determine whether you're participating with that patient's plan or not. Mm-hmm. You have to sign up and subscribe to electronic insurance verification and eligibility of benefits. That is going to tell you whether you're in network or not with the patient's plan. It's also going to inform you of their copay. It should provide you information on any deductible they haven't met and other information. But the biggest and most important document that every practice should have, which none of them do in this country, is the patient's policy, because that dictates what's covered, what procedures need prior authorizations, and we all know payers ask for those every day, every week. Mm-hmm. And many of them are illegally requested. So, you don't want to be doing things that you don't have to do, but just because the payer asks you to or tells you to, mm-hmm. does not mean it's legal and does not mean they are correct.
Yeah.
Because they are going to make you jump through hoops. Because let's face it, insurance doesn't want to pay a claim.
Yeah.
Their job is to keep the money in their bank coffers. Yeah. Okay. Your job is to get the money. Our job is to help you get the money. Yeah. So we want to evaluate those payers based on, so for instance, if we had an HMO policy that is covered, it covers 15,000 lives. Well, if you're in the state of Texas, chances are we're not going to waste your time and money to get you credentialed with that plan unless you tell us you have patients that have that plan. Mm-hmm. Otherwise, we will wait and hold off on that plan until you obtain a phone call from a patient and need that plan under contract, mm-hmm. because we don't want to waste your time and money. So what we normally do is we'll evaluate based on the state, the area of the state that practice is located in, and we'll make recommendations on which plans they should probably consider contracting with. Ultimately, it's always the client's choice. They make the decision and they tell us what our work is. So we let them make that decision, but we do give them advice and counsel so they can make an educated decision.
And what are some of, what are some of the factors that so, patient continuity, big deal, makes a lot of sense. What are some of the other,
well, first
points
off,
of recommendation?
If you're bringing patients on with you, then we definitely need to get you in the plan that patient's in.
Right.
And most often we have no issue with that because we explain to the payer or the insurer that, look, you're already contracted under a different contract. You're separating from that contract, starting up a new practice. A good suggestion to your listeners, if they are leaving employment and they're going to set up their own practice, start getting, maybe draft a form letter and have your patients sign it that they want you in network because they want to continue to see you and follow you. Now, you need to be careful. If you have a non-compete or restrictive covenant, there are different ways to do this so that you don't get in trouble for soliciting the patients of the current employer.
Mm-hmm.
Okay, so they can definitely talk to us and we'll walk them through that. But obviously, we want to make sure they're in network with any plan that they have patients for.
Right.
Secondarily, we can also, especially if you're a specialist or even primary care, if there are not a lot of providers in the community that are accepting new patients or they're scheduled far out, there are ways of figuring this out as well. You've heard of the mystery shopper status before.
Mm-hmm.
Either we or the practice or the provider can act as a mystery shopper, call their competition, ask them if they have new patient office visits available, and then ask how far out they're scheduled. You either put a check mark for yes, that they taking new patients or not, and then let us know how far out they're scheduled. And then we can communicate with the payer, especially when they say, oh, we have network adequacy, like we're dealing with an anesthesia practice now. And Humana told us they have network adequacy. So I figure, okay, I'm going to poke a hole in this one because we know better. In that community, there are three anesthesia groups in network, and they are at least 50 miles away from where the client's practice is.
Mm-hmm.
So network adequacy, not quite, not even close.
Yeah.
So their whole reason for not contracting doesn't hold water, and we will file a complaint with the insurance commissioner for the state. We can file a complaint with CMS because they also have a Medicare Advantage plan, and CMS wants them to be covering patients if they're going to carry a plan. So them stating they have network adequacy when they don't, there are repercussions for insurers that communicate that when it's not true.
Right.
So we evaluate on many different avenues here in order to figure out who they should contract with.
Is there a sweet spot on like the number of insurance companies you want to sort of take? Like, is
Not
it 2?
really,
is it 22? Is it, you know what I mean?
Yeah, it all really, Carl, it all depends on how many plans there are in that state or area and how many lives are covered. Because let's say, okay, you're going to contract probably with usually the 5 big payers, although Humana is no longer doing commercial insurance. They're Medicare Advantage only. They also, Humana Military handles TRICARE. But at this point, you've got Aetna, you've got Cigna, you've got United HealthCare, Blue Cross Blue Shield. Okay. Then you have Medicare. I mean, who else are you going to contract with? Then you've got all the regional payers or smaller payers. So you really have to evaluate, okay, how many lives are covered? Do you have patients covered under those plans? What makes sense to contract and how many payers make sense?
Mm-hmm.
I've got clients that have maybe 5 to 10 insurers that they contract with. And then I have clients with 80 to 125 payers. Yeah, it's a lot of work. Considering I got one client with literally 300 providers. They're located in Illinois and Arizona, and we've got massive quantities of insurers. So out of 2 states, that many providers, the tally of payers starts increasing.
Yeah.
We've got an awful lot of contracts that we're dealing with for that one client.
Yeah, I'll bet you do. Yeah,
And you got to be able to keep track of it too.
yeah. Well, yeah. And then when do you renew? When do you renegotiate, et cetera, et
And the
cetera?
other, other evaluation areas are, okay, what's the reimbursement? Are they going to pay you reasonably well?
Yeah.
Are they undercutting Medicare? I mean, those are other areas that you need to evaluate. Then on
Yeah.
top of it is, okay, how many prior auths are you going to have to do? Are they going to play games with denying services? Are they going to play games with, like Cigna right now, they want to lower the E&M code if you're billing level 4s and 5s without even asking for records. I mean, that's just garbage.
Yeah.
I mean,
Yeah.
you don't want to be dealing with stuff like that. So you really need to understand the payers, what they're starting to require, and whether you want to be jumping through all those hoops. And then on top of that, how many providers want to participate with Medicare Advantage? Because Medicare Advantage is not Medicare. Medicare Advantage can deny services, and they will.
Mm-hmm.
They will require prior auth and yet still deny the service when you have the authorization number. Yet Medicare doesn't do any of that.
Yeah.
So Medicare Advantage and Medicare are not one and the same. And Medicare Advantage plans are required to pay you the Medicare fee schedule if you're out of network. It just means if you're out of network, you're not on their provider directories, and you're not going to see a lot of those patients.
Right.
So being out of network is fine because you can bill more, but chances are the revenue isn't going to be generated. The revenue that you're going to generate is not going to be that high simply because there aren't as many patients willing to pay more money out of their pocket with disposable income when they're paying a premium for their health insurance.
And you hit on a few things in my next question about just going one level deeper about evaluating. Just look at my notes here, evaluating the payer, the contract, the rates, the timing. I think of it as you run a business and there's revenue and expenses, and you do some planning, you do some prediction. At least you have some sense of what your expense base is, and then you build the revenue up. It's some back and forth between the two as you get to a point where you say, all right, this pro forma, which is what that is, this looks like something to go after. How do you, like, in your and my world, we don't take, there is no insurance, right? We bill at a rate or we bill at whatever. It's just, it's simpler. How do you do that with all
As
of
far
this?
as building a pro forma like for a startup?
Well, or you're changing contracts or you're changing carriers, or I know it's doable, but you say, well, I'll make it up. We're going to collect $150 for every patient visit. And then you go out there and you get 110 because that's what you can negotiate, or that's what the local market. Oh my God. Like,
Sure.
It's just, how do you do this?
Well, from the standpoint on ensuring that you're getting paid appropriately, one, there are other tools that we have to evaluate payers as well.
Okay.
You can pull contract rate data that every payer is required to post to their website now.
Okay.
Now, your listeners aren't going to see this data unless they're willing to pay a lot of money for that data.
Mm-hmm.
It's not out on a website where you can just download the file. There's special files, you have to have software, and then you have to have somebody that knows how to manipulate the data because it just looks like a CSV file with a bunch of data all run together.
Mm-hmm.
So you can't make heads or tails out of it. You need an analyst that knows how to understand the data,
Mm-hmm.
and then can put it into pivot tables and spreadsheets so that you can see, okay, this competitor of mine down the street with this NPI and this tax ID is getting paid this amount for this CPT code, and then this other competitor is getting paid this amount. Geez, we know what the payer's willing to pay. Now let's see if we can go get that amount for our client.
Right.
Or, we're going to see 5, 6, or 10 different competitors, and that one may be at the bottom of the totem pole, one may be at the top, everybody in between. And we can see a vast array of reimbursement rates that are being contracted by that insurer.
Mm-hmm.
So all of this is public information. You just have to be able to pay for it.
Yeah.
So that's what we do. We obtain that on behalf of our clients if they so choose.
Mm-hmm.
And we'll bill them for those services. And we can provide that to them, but it's a heck of a tool for us so that we can utilize that data and negotiate on their behalf and hopefully negotiate a better rate for them.
Yeah.
Even if they're a startup. So we do that all the time. And between that where the payer is, how much they're willing to pay, what their requirements are, all of that kind of stuff. We evaluate those insurers based on that criteria, and then we communicate it to the client, make them aware of what the pay is, give them a copy of the contract, give them all the rates for all the services they're going to provide, and ask them, are you willing to accept this contract? And if they are, we execute that contract and get the process going. If they aren't, then we leave it on the table and tell the payer, thanks, we have no interest. We will be seeing your patients, but you'll be paying through the nose for it because they weren't willing to contract or they weren't willing to pay you enough. So we'll do that, but many times we can get you in contract because the payer doesn't want to pay more, and they don't want their patients or their members paying more out of pocket either.
Yeah.
I mean, one of the criteria that every insurer looks for is, how are you lowering the cost of healthcare? So, one way is to provide services in-house, not perform procedures in a hospital OR, not refer patients out to an out-of-network provider, many things that can make you look very good to a payer rather than a black eye and a red flag where they want to terminate your contract.
Right. What are some, other than there aren't many covered lives in the local area, what are some red flags you see from payers where you look at a client and you say, I don't know if you should contract with these people or this particular plan? Or
well, sometimes we're going to get a client that, like, we have a ton of clients in Texas. We got quite a few clients in Arizona, in many states. And because we've dealt with the payers before, we already have an idea on what's going on. We've got clients all over the country. I'm going to guess there isn't a state or territory where we don't have knowledge about most of the payers.
Mm-hmm.
And in many cases, like we all know, United HealthCare requires a lot of prior auth. They don't update their provider directories on a timely basis per the No Surprises Act. So that creates havoc for clients because it looks as if they're out of network, or a provider is, when the provider's credentialed. United HealthCare just didn't update their directories. There's all kinds of issues the payer can cause, and they do, and they will. So how do you hold them accountable? It's knowing what the rules are, communicating with them, and forcing them to follow the rules.
So you don't really say to them, you know what, you should just walk away from United HealthCare. Instead, you say, here's the bed you're getting into if we contract with United HealthCare. We
always inform the client of what our knowledge base is. We can make a recommendation, but again, the final decision always falls with the client.
Have you ever recommended to a client, we really don't think you should contract with them?
Oh, absolutely.
What's an example of that?
Multi-plan. Multi-plan isn't even an insurance company. They're a discounter and repricer. So like you could have a contract with United HealthCare, Aetna, Humana, and Cigna.
Okay.
Those 4 national payers. Multi-plan contracts with those 4 national payers. And if a PHCS or Multi-plan's logo is on their insurance card along with United HealthCare, guess what? Your United HealthCare contract, if you have a contract with Multi-plan, holds no water. Multi-plan's going to discount it and pay you less.
So is Multi-plan just like an
aggregator contract with Multi-plan?
Is that like an aggregator? They're trying to make things just go to us. You don't have to go to all these different insurance companies. Is that?
No, they contract with insurers. Because what they get paid based on how much money they save the insurer.
Mm-hmm.
So let's say United HealthCare, you've got a contract with United HealthCare to pay you $150 for a level 3 office visit. Okay, but if you also have a contract with Multi-plan, United HealthCare is going to send that claim to Multi-plan and tell them to discount it. And then you're going to get an EOB that says you're paid less. They're not even going to ask you. You're just going to get paid less. And then you're going to wonder why.
So what is Multi-plan's proposed value to the provider side?
There is no value to the
No,
provider.
I know, but what do they say?
Well, they don't, because they're not an insurer. They aren't out there trying to get providers to contract with them. What they're doing is they contract with the insurers and they automatically make money. The insurers pay them.
Got
it. So they don't need providers.
Okay.
They just need the insurers and then they automatically get the patients and those claims, and that's how they make money.
Okay. I thought it was like in the hospital world, there's these things called group purchasing organizations where their value is, hospital, you buy from us and we will be thousands upon thousands of suppliers of stuff you need. You get it all through us. We centralize, we make it easy for you. That's kind of what I was thinking, but it doesn't sound
Yeah,
like.
that's not what this is. I mean, that's for buying supplies, office supplies,
But the
things
concept,
like
yeah,
that.
yeah,
Yeah.
okay.
So it's definitely, they're called a repricer. I mean, in Pennsylvania, they have other payers like Devon is a repricer. And many states have those kinds of payers. Now, multi-plan isn't even multi-plan anymore. It's Clarative. So Clarative, PHCS, multi-plan, Devon. There are many repricers out there. So you have to be careful and know whether they are a repricer or whether they're an actual insurance network. Because Clarative and multi-plan has nothing to do with insurance other than the fact they work with insurance companies to pay you less.
Got it. Okay, so that's one red flag. Any other red flags where you say, Dr. X, you should not contract with them because?
Well, for instance, right now, Blue Cross, they're a pain. I mean, they will not pay you. I've got an anesthesia provider out west that had a recoupment of hundreds of thousands of dollars. Yet Anthem paid the surgery center, they paid the surgeon, but they didn't pay the anesthesiologist. Well, guess what? Anthem's going to pay our anesthesiologist because they paid everybody else. You cannot not pay one provider and yet pay all the other.
Hard to have a surgery without an anesthesiologist. I think
exactly.
the guy was there.
Whether they're out of network or not, you're still going to pay them if you paid everybody else.
Yeah.
And they have to. And, some of your listeners may not know this, but there are managed care laws and regulations in every single state. And we know every single one of them that's going to hold those payers accountable, including the federal ERISA laws that even in, your intro covers 80% of the claims in America.
Yeah.
So there are a lot of things that payers cannot and are not allowed to do that are illegal that you just need to know this, and then you can hold them accountable. You can report them to the OIG. You can report them to the insurance commissioner. There are so many ways to hold these people accountable.
Yeah.
We love doing it because we just laugh all the way to the bank with our client because we're telling the payer what they can and can't do.
Are there any good payers out there? Are there any good ones? Like in the context of payers, who are the good ones? Maybe just the good ones right now. I
don't know of any good insurance company.
Okay.
And I've been doing this a long time.
Yeah.
There's no such thing that exists.
Has it gotten worse over time in your experience?
I've been doing this 30 years. We've been doing credentialing for 30 years. Credentialing's gotten tougher. And that really got tough on March 17th of 2020.
Well, yeah.
When everybody was sent home to work. Because you can't reach anybody anymore. And then on top of it, all the payers, they do everything to play games. They removed all their provider rep contact information from their website. They don't put now, given the whole United HealthCare debacle and the CEO that got shot, you've got a lot of executives for insurers that are being removed from the website. I mean, even Congress this week has mentioned that, the possibility of an insurance company executive getting in trouble with a patient is very high risk right now. So, I mean, you don't know what the heck's going to happen. I mean, people just use violence as an answer for everything. And that is just ridiculous.
Yeah. It's funny. Every once in a while, like on CNBC or whatever, I'll see, so-and-so they're a good buy right now. And I stare at that. I go, I don't know how you can say that. Like, just forget the morality of the cheaters and all that stuff. I'm like, I don't know. I mean, their CEO could get injured tomorrow and that's not good. I don't know. I mean,
think about it. Look at United HealthCare. I mean, they just got busted and had a $79 million decision against them for a class action lawsuit they've got all kinds of lawsuits against them.
Mhm.
Every payer does. All of them I've mentioned today, even Anthem, have all kinds of suits against them by the government, by physicians around the country, and so on.
Yeah.
They don't care. This is pocket change to them.
Yeah.
You've got a United Health Group that's making probably $1 trillion in revenue,
Mhm.
and they have to pay $1 billion for a fine. What do they care?
It's pocket change. Yeah.
It's pocket change.
Yeah. Yeah. It's
So they don't care anymore. That's
yeah.
why every single payer I've mentioned automatically reduces E&M codes without even looking or requesting a medical record to
Yeah.
validate whether the provider actually provided the service and supports what they billed. They
Yeah.
don't care anymore.
Yeah. It's just funny, like, you know, the business model of insurance generally is wonderful. You collect the premiums, you invest it for the float, and you pay out as needed. But it, you know, the business model for health insurance depends on the ignorance of their subscribers, which I don't know. That wouldn't give me much comfort, but
I mean, think about
I'm
it.
not in that business.
You're a patient, I'm a patient.
Yeah.
Do you know where your policy is?
Oh.
Have you ever read your health insurance policy?
I read what, so we get it through my wife and they send out what feels like very detailed, but I can't tell you if that's the policy
So
or
you
not.
probably either get, so you should be getting, every patient should, the HR department at an employer is required to hand out a copy of the policy and also another document called the summary plan description.
That I
has to
definitely
be
get.
handed out for any health benefit plan. Okay, any kind of benefit plan, whether even if it's your retirement plan, every year they have to provide details about that plan to their employees. So, and a patient should be requesting a copy of that policy, should be requesting a copy of the summary plan description, because think about it, if there are patients listening to your broadcast here, okay, you've got United HealthCare that requires a prior auth on a procedure, then they deny that procedure. Guess who now is responsible to pay for that procedure?
The patient.
The patient.
Yeah.
Now, don't you think the patient wants to know whether their insurance company did this properly or not? And do they pay attention to the EOB they get in the mail? When you look at that EOB and let's say you're the provider, you build a level 4 office visit, and all of a sudden that code's removed from the EOB. It just says office visit now.
Actually, no, I'm going to cut you off. We just get pissed off at the physician's office because how could you let me do this if it wasn't going to get covered?
But it's not the physician's office,
which is part of the problem. That's right. It's not exactly.
The insurer changes the information on the EOB, puts down OV instead of a 99214, so you can actually tell what that is. The office gets a copy of that EOB, and they, unless they go back to the claim they submitted, they have no idea what that OV stands for.
Right.
And then they'll see an amount next to that OV. They lowered it to a 2 or a 3. That's what they're going to pay you, and yet your claim was a 4 that you submitted.
Yep.
Okay, I want everybody that's listening to go look at those EOBs, and every single EOB is not going to match the claim you submitted.
Yeah.
That's how payers rip you off.
And so when we talk about, you know, our topic, evaluating companies and plans, this just sounds like, I don't know, a day in the life. Like there's just, you know, so I guess evaluating, to bring us back, it's all right. So covered lives makes sense. And then maybe it's what sort of I surmised earlier, which is just understand the rules of the road for the companies that you're going to, none of them are easy. They're all kind of deceptive in their own ways. The deceptiveness changes on a day-to-day basis. And the premium is to stay on top of that so that you can get paid what you're actually owed in a reasonable amount of time. And that's...
Yeah, and here's how we hit the easy button on this, okay? Because you asked me to make sure I tell you, okay, how do you make this easier? You get somebody in your court that knows the laws and the rules and can hold somebody accountable.
Yeah.
Most billing companies don't know how to do this. You ask any of your billing companies if they know what the ERISA laws are, and it will fall on deaf ears and nobody will be able to tell you anything.
Yeah.
You ask them about the managed care regulations in the state. they won't even be able to tell you where to find those.
Mm-hmm.
So billing companies aren't trained either. And that's the problem. There are too many billing companies in this country that don't do their job
So
properly.
they can process it, but if when problems arise,
they don't do a good job at it.
Got it.
So my suggestion to your listeners, you find somebody that knows what they're doing, does it properly. Now, that's going to be a challenge for most providers, because when was the last time they learned anything about business? Way back in their undergraduate degree, maybe 13 or 15 years ago.
If that.
If that. So
not a lot of business in biochemistry. Yeah.
Yeah. You need to vet your experts, your consultants, your advisors properly, in order to understand whether they know what they're doing.
Mm-hmm.
Hire somebody that really is going to, when you're getting contracted and credentialed with a payer, you need somebody that's going to guarantee you in writing you're going to get copies of fully executed contracts. So you have proof you're in network.
Mm-hmm.
You're going to get copies of all your fee schedules. And by next year, the payer is going to change those fee schedules. So how do you keep on top of that stuff?
Mm-hmm.
Even though you signed a contract, deep in those contracts, that payer gave themselves permission to change your rates, even though you agreed at certain rates.
Mm-hmm.
So it's all about hiring the right people so that, yes, you want to be a doctor. Let's let you and allow you to be a doctor, and let your advisors protect you.
Yeah. So on our topic, we covered a lot. On our topic of, evaluating companies and plans, anything you think we missed?
Well,
with the caveat, this could be an all-day discussion, but I mean, anything you think we missed?
Again, looking at the right payers, going out there, hiring the right people to get you the right contract,
mm-hmm.
and advising you properly. Look, this is a good contract. Look, this is a bad contract. And then ask the question, what determines a good and a bad contract?
Yeah.
And make them explain it to you.
Mm-hmm.
If they can't do that, I'd go find somebody else and fire that company, or that consultant.
Yeah.
After they've explained it to you, make sure you get a fully executed copy of your contract. Get your reimbursement rates. Make sure your billing people have all that information. Plug in those fee schedules into your billing system so that software will notify your billers whether you were paid properly or not.
Mm-hmm.
Every once in a while, go through and have an evaluation done on your revenue cycle and make sure that you're getting paid properly, because you're not going to know unless you evaluate what was paid by the patient, both with copay and the deductible, whatever was paid by the insurer, and those three items should match the allowed contracted amount.
Right.
If it doesn't, go back and ask for the rest of the money.
Yeah.
Okay, so do that and then follow up with the payers. There is nothing that says you can't negotiate with a payer, but you need to have leverage. So you need to know about yourself, your competitors, how you do things better than your competitors, and know what you bring to the table, because you're going to have to communicate that to the payer, even though the payer knows everything about you already.
Right.
Because no payer wants to pay you a dime more unless you can make a case on why they should. And that's our job when we do contract renegotiation.
Mm-hmm.
We want to glean every piece of information in order to help that payer understand, look, you've got an exceptional partner here in this practice. You better pay them more, otherwise they're going out of network, and now you're really going to pay through them.
Yeah. And how much time, like rough rule of thumb, like to do this well, for a practice to do this well, how much time would you say they should kick off this process of their reevaluating, or they're looking again, or they're starting up to get this good?
If you're starting up, you can't start too early evaluating the payers and starting the credentialing and contracting process.
Mm-hmm.
Although most payers, if your first date you're going to see patients is 6 months from now, well, we're not going to communicate that to the payer.
Okay.
Because we want them to get moving and show some effort in getting things done quickly. So we're going to make them aware that, hey, we're going to open in 3 months and we need to get this moving. You need to stay on top of them. And my suggestion is credentialing and contracting takes time now. Most payers are going to take 3 to 4 months for the major ones. Other payers are going to take 3 to 6 months to complete. Every payer gets to make their own rules. And if you have a problem with that, go talk to your Congress people, because they're the ones that allowed this. Every payer makes their own rules. They get to decide whether you participate or not, and they have carte blanche to say anything they want. Therein lies the problem. So unless we start realizing this and start voting in people that are going to actually work on our behalf in Congress, this isn't going to change.
Okay. So 3 to 6 months.
Yeah, 3 to 6 months to get that done. In most cases, most payers will be in the can and contracted in about 4 months.
Okay.
But you're still going to have those stragglers that are going to take 5, 6 months.
What about if you're not starting up, credentialing isn't needed, but you're looking at, changing plans or changing carriers, or just how long?
Well, you can evaluate whether you want to stay in network with a payer. In those kinds of situations, we kind of walk the physician through or the owner through, okay, how many patients have these plans? How many fill your schedule up? How many slots are going to be empty? Can we fill those empty slots on the schedule with other payers that pay more? Okay, so, I think we may have talked about this before, maybe we didn't, but a lot of doctors always tend to want to drop Medicare. Medicare is the best, quickest payer in the country. 14 days on a clean claim. You try to get payment from any other payer in this country in 14 days, not going to happen. So cash flow happens very quickly with Medicare. Medicare pays decent rates. They don't pay great, but I consider Medicare the floor that we want reimbursement on.
Okay.
Every other payer should be higher than that. Now, it isn't going to happen, but some services can be increased. And you want the main services that create 80% of your revenue to be the best reimbursement, because those are the services you're going to be spending most of your time on.
Right.
So we're going to look at that. We're going to help you understand all of this. And even in Medicare, how are you going to replace those patients? Are you going to be able to put Blue Cross Blue Shield patients in there? And will they pay you more, or are they going to pay you less than Medicare? So does it make sense to drop Medicare? I haven't found a situation yet with any client where the client realized, yep, I was right, I'm dropping Medicare.
Wow. Yeah.
After all is said and done, they all agreed, you're right, we shouldn't be dropping Medicare.
Okay.
It's not a smart decision.
Okay. Okay.
So that's how you're going to evaluate whether you keep a payer or not. Understand who's going to replace them in your practice and whether that replacement is going to realize additional revenue for you. If it doesn't, then it doesn't make sense.
Which is a pretty thankfully straightforward way to look at it, because it doesn't sound like you could choose based on hassle factor, because they all have massive hassle factors.
Well, yeah, I mean, Medicare Advantage. You could drop Medicare Advantage plans and keep their commercial plan if they allow you to do that. But again, if you're getting a lot of prior auths and a lot of denied claims, then maybe you want to, drop that plan.
Yeah.
And usually, especially on Medicare Advantage, if you're dealing with Humana, they pay 70% of Medicare, worst payer in the country. Never contract with Humana Medicare Advantage.
Wow.
It makes no sense.
Okay.
You will get paid like Medicaid rates.
Wow.
Not quite, but pretty close.
Okay. Okay. So the other wrap-up question I ask is essentially, where can somebody get started? So the large topic, this is like very, very large topic. And the context is we've caught a listener's attention, hopefully a lot of them. David's right. We need to get better at this, but it's such a large question. What's something simple somebody can do just to get kind of off the starting line and moving? Practice.
Call us.
Yeah.
Seriously.
Now, normally I tell you, listen.
Your listeners can call us. It doesn't mean they need to contract with us.
And normally
a little advice, I'm happy to give it.
Yeah, normally I would push a little bit on that and say, what can somebody do on their own? But in this particular topic, I don't know if there's a simple place to I don't know. It's such a
Well, I'll tell you
freaking
this, Carl.
maze and minefield like this. Do you really want to do it yourself on this one? Maybe,
Well,
maybe, but man, oh man.
in the last 5 years, we have more people asking for assistance with credentialing and contracting because everybody hates it. It is
Mhm.
just a nightmare to get yourself involved in. Just the lack of communications from payers. We see it happening. More and more people are saying, I can't deal with this anymore. I'm outsourcing it. And then they outsource it and they find that they didn't get a company that is doing as good of a job as they should. Do your homework, ask for references, find out if they give you fully executed contracts and fee schedules. Additionally, we take care of all CAQH attestations. We make sure that all provider directory updates are done every 90 days, all providers, all payers, all plans, as long as we get those communications from the payers. So we're going to try and take all this garbage work off
Mhm.
the client's hands
Mhm.
so they don't have to worry about it anymore
Mhm.
and do it behind the scenes. Even their recredentialing and revalidations get done sometimes without them even knowing we're doing it.
Yeah.
Sometimes they don't even need to tell us because I log into Pecos on Medicare and I see whether their revalidation is due.
Mhm.
So we can do things in the background and never have to ask them a question on some of this stuff. That way they don't have to worry about it and they can just go about seeing their patients, which is what most providers want to do.
Yeah. I mean, it's in an abstract way, it's too bad you have to do all this extra work just to get paid for the service you already provided. But here we are. Um, that ship has sailed decades
Yeah.
and decades ago. So, in any event, well, David, thank you for coming back on Practice Care.
Absolutely.
I don't know how we tackle these topics, but we seem to try to make some sense of it at least. So I really appreciate it.
Sure.
Yeah.
Happy to
And
be here, Carl.
yeah, absolutely. We'll have you back and we've got your contact info. So, when David said call him, contact them, he means it. All of his contact info is in the show notes. Easy. That's just another way now to get a hold of him. So anybody who wants to do so, go there. 2 quick points before we wrap up. First, subscribe to Practice Care, please. We just recorded our 200th episode. It hasn't launched yet, but it will pretty soon. So chances are that if you've got some question on the business side of private practice, one of our guests has answered it or has come close to answering it. So check us out. But the easiest way to find them is to subscribe. So Practice Care is one word. We're everywhere, easy to find. Just subscribe. And the other point is, if you're like David Zetter or us and you serve private practice owners, or if you're a private practice owner yourself. Either way, you've got some experience on the business side of practice. And don't overthink this. Any experience is good experience. If you figured something out, I promise you, somebody else is struggling with it. Come on Practice Care. Tell the world about it. We'll get you scheduled as soon as possible. In the show notes of every episode, there's a link, a couple of click, under a minute, you're done. We'll get you on here and you can share your knowledge with the world. Thanks very much. And until next time.